Thank you everybody for coming, and welcome to the second Comedy Matters research seminar. The structure for the afternoon is that the first hour will be the paper and the Q&A at the end, and then from 5 o'clock there'll be a drinks reception. I've also been asked to mention that we're all being filmed, so we're all on camera, even if only peripherally. So our speaker today is Dr May McCreaddie, who's a senior lecturer in the School of Nursing, Midwifery and Health at the University of Stirling. She's also a nurse who's worked in many settings, including the NHS, health promotion, India, Romania, and more recently education. She briefly spent some time as a stand-up comedian in the late 80s, early 90s, including on one occasion being on the same bill as Lee Evans at Comedy Store in London. And this, as well as her first-hand experience of the importance of humour when working with patients and peers, has made humour in healthcare interactions the main focus of her doctoral work. She's published widely from her thesis. She leads the communication theme in the undergraduate curricula, where authentic research data and humour feature prominently, and her current research utilises a broad data corpus of NHS complaints data, including written and audio recorded material, to review routine healthcare interactions, and she's undertaking this work with Bethan Benwell at the University of Stirling.
Okay, thank you very much, Leon. Can everybody hear me? Okay, great. Well, thanks very much. It's always a pleasure to come down here to Britain. And I can say that as somebody who's voting no in the independence referendum. This is where I work. It's the University of Stirling, and that is the university sits in the sort of shadow of the Wallace Monument, so it's quite a historical setting. There's always a problem when you don't have your specs on, you can't see the cursors. So what I was going to cover today is basically why humour, why is my interest in humour, an introduction to humour, sort of previous research in this particular area, the research that I'm doing and why I think it's particularly different and why it might be interesting. And I'm going to use the findings and show you sort of two comparisons between a baseline data corpus drawn across a different range of settings and a specific clinical nurse specialist who worked with a particular set of patients, and to show you the differences in these two. And then maybe very briefly then talk about potential for application, which I'm sure if there's many of you working here in healthcare settings, you might be interested in that. Why humour in healthcare? I've worked in a variety of settings, as Leon mentioned. Have been on the television, and it wasn't Crime Watch, so that was good. And I've worked in a variety of areas. It's interesting that you see in all those areas, in dealing with a bigger crowd and doing stand-up, and then doing teaching and having to change it very slightly for teaching, and then working with people in a sort of very nuanced interactional basis. You can see why humour is so important and why it's such a central feature of communication, and why it's essentially about humanity. And it very much is, it's been said, the shortest distance between two people is a shared laugh, and I definitely concur. Humour exists across a variety of settings, including across generations. And I particularly notice this picture. I do like that everybody's got matching trainers on, which is good. It also exists in institutional contexts. Like you see there, I don't know why that lady's trying to take the pulse in her right breast. I'm sure there's a good reason for it. And also it exists in what are quite often tragic situations. And this was taken a number of years ago, or another way to put it would be several stones ago. In 1991, when I spent some time in Romania working, and certainly when you work in those settings, it can be particularly challenging. Humour is absolutely integral. to how you kind of mitigate the difficulties that you face on a daily basis. So, humour, just to very briefly, just talk very briefly about humour. It's known as a stable expression of personality in humans. You may be familiar that there are a number of humour theories. There are actually over 100 humour theories, but the three main humour theories are the ones that persist. The superiority theory, that includes sarcasm and self-disparagement. Incongruity, which is the simple setup and the punchline that's at odds with the setup. And release, which is Freudian approach, which is the cathartic humour, the release. And all of them are sort of motivational theories of humour. You may be aware that there's an International Society for Humour Studies, and there's also an Association of American Therapeutic Humour, Applied Therapeutic Humour. And previously, for a while, there was also a Journal of Nursing Jocularity, which actually ended in about 1997, but I do believe there's a blog that still does some work in that area. And what you'll find is mainly that Journal of Nursing Jocularity, you'll get a lot of the applied humour specialists there, so that'll be clown nurses or nurse clowns, and I've worked with both, believe you me. The thing to say about humour is that most of the work that's done in this area is around about rehearsed humour, so it is about stand-up, or it is about asking people to look at cartoons and try and measure their sense of humour. The area that I'm really interested in, I think, is an area that's much more fascinating, and it's about spontaneous humour, how humour arises in social circumstances. For me, that's real world, it's natural, and having worked in the NHS abroad and so on, you really get a sort of keen interest in how people express themselves and how important humour is to interactions. The sort of work that's been done in this area largely revolves around the humour health hypothesis that contends that there are positive benefits from humour, whether they are direct benefits such as physiological and emotional mechanisms, or indirect benefits, so they promote social support, decrease loneliness, improve stress, coping mechanisms, etc. Certainly indirect mechanisms have more evidence base than the direct mechanisms, and the direct mechanisms are much more difficult to prove. And there's been numerous studies done looking at showing people humorous videos and then measuring their immunoglobulins, their salivary immunoglobulins, and things like complement C3 from the complement pathway. But these studies are incredibly difficult to do because a lot of these mechanisms and a lot of these immunological markers are very difficult to capture. So there's massive methodological problems with doing these particular studies. But what we do know is there is probably a benefit directly, but we know there definitely is a benefit indirectly through increasing social support. But we do know that all of that work's primarily been done on rehearsed humour, not spontaneous humour. The methods tend to be that they use healthy subjects, so they're not people who are unwell and who are the kind of people that attend hospitals. They tend to be using scales, so they measure your sense of humour, but they don't always correlate your sense of humour to the intervention. So these are where the methodological problems come in, and they tend to be done in psychology students in laboratories, right? I'm not saying anything, right? Also, more recently, there's been a positive focus. You'll be aware of the positive psychology movement, etc. Started up with Seligman, etc. in the sort of turn of the century. And they've identified the 28 traits, one of which is humour. But I'm kind of ambivalent in that because I do think there are potential detrimental effects of humour and humour use, and we have to be very careful. The interesting thing is that any work that's been done in my area in nursing, there's been very little work done at all. The work that has been done, it's all opinion based, and unfortunately it tends to talk about exclusion zones. It tends to talk about when you shouldn't use humour rather than when you should use humour, and that is all a little bit disappointing, I think. There has been work, you might be familiar with some of the work done in the linguistics area by Philip Glenn, Laughter and Interaction, looking at laughter as humour support. And there's been a lot of work done in that area using conversation analytics studies. And then you've got Jennifer Hay, who's done some work on non-laughter support. Right? And I think the second area, Jennifer Hay, that work is actually really important because not everybody reciprocates via laughter. I remember going to see Norman Lovett once when he did stand-up, and he talked about it important that you mind your 3 Fs when you start to do stand-up. So the first F was make sure your fly's up, the second F was make sure your flaps are out, and the third F was face the front. And he always used to say, smiles are no use to me, it has to be laughter. And I think, unfortunately, a lot of the work's been done in this area concentrates as laughter as a means of humour support, whereas humour can be much more nuanced and subtle. And sometimes we don't pick it up and sometimes we don't reciprocate, and particularly in difficult, dynamic, complex settings like, you know, hospitals where people are ill and anxious and so on. So, particular study that I'm going to talk about and the data that emerged from it looks at spontaneous humour in situated interactions and contexts. It used a constructivist grounded theory approach, and that was used because I wanted something that was flexible and allowed me to go and capture the data that I needed, and then analyse it in an iterative way, and then go back and get other data as I needed it. The main problem, I think, in any study looking at humour is how do you define or interpret humour? How do you determine that humour has taken place? Do you judge it by laughter, by a smile? Is it more subtle than that? So how would you define it? And how would you then demonstrate it had happened and therefore could be repeated if you were looking at other studies? And that was a big problem for me, and has been a problem I think for other researchers. Is it humour, laughter, both? What exactly is it I'm looking for, and how will I know when I've found it? Right. And to kind of demonstrate this guess, I'll show you this slide here. Right. Now, confession time. I am a member of the Rabbit Welfare Association. Right. I know some of you are looking at me there as if I've just said I'm a member of Al-Qaeda. Right. There's a difference. Right. And I have a couple of house rabbits. This is one of the house rabbits I used to have. This is Cooper. And as you can see in this picture, Cooper is laughing. Right? Would you agree that he's laughing? Do you know why I know he's laughing? Because I've just told him a joke and then I took the picture. It's the joke about the fox and the ferret. Have you heard of it? No. He's heard it umpteen times, but it cracks him up every time I tell him it. Right? He's actually yawning in this picture. He's not laughing, but rabbits do laugh. There's a slight sort of different sense of slight opening in the mouth and so on, and the way they sort of flex their body. But in this particular picture, he is actually yawning. He's part of a bonded pair, and his mate, Corrie, I'm a wee bit worried about her lately. Think she's not looking very happy, might even be a wee bit depressed. Now, to emphasise the point about this picture, this is quite a good example of what might be construed as incongruity humour. It's incongruous in different levels. First of all, that a rabbit would read a book, that book would be about bunny suicides. And obviously if you're a rabbit, you've got one eye on either side, you've got one eye on each side of the head, so you could read the start of the book and the end at the same time. But this is a good example of the different challenges in trying to capture humour, but also trying to pull it out, extrapolate it, and try and make sense of it for other people, because some of you might look at that picture and appreciate it and think it's quite funny, other people might not. Everything's very, very different. You know, it can be very, very subjective. So if something's very subjective, how do you actually capture that? So what I did was I developed an interpretative and illustrative framework to try and analyse the data that I collected. And I used it as a sum of parts to recognise that no one thing was going to give me the answer, that I needed to capture a range of aspects that I was looking at. So I used what we know from the literature, and then also tried to facilitate what is unknown. So what is known from the literature is we know about the humour theories, and we know about the three main humour theories: superiority, incongruity and release. Also looked at Jennifer Hayes' work using humour support, so the non-laughter based aspect of humour support, and drew upon that to look at certain situations where we could say that that's occurred. There was also the sort of illustrative aspect of not just what is said, right, that you can look at and try and interpret by a humour theory, but also how it's said. So I used the work, the data that was collected was mainly audio recorded data, and I'll come on to that in a minute. So I used the Jefferson Light system, which tries to capture the different intonations of speech, all the prosodical features of speech, breaths, inhalations, exhalations, smiley voice, etc. So that was not just to show what was being said, but also how it was being said, which is quite important. And then at another level, at the level of axial coding in the grounded theory that I was using, try to look at the context, and this is work that's been done by Rod Martin, and he looks at, he's a psychologist, different areas of social, emotional, physiological. So basically some of the potential antecedents of the situation that we're looking at. So you've got what people are saying, how they're saying it, and what is the context. So trying to capture all of that and therefore paint a picture to say, well, could this be humour, or what might it mean? And so that was the framework that I developed and subsequently used. The interactions that were studied, there was a baseline data corpus. Clinical nurse specialists, whether you're familiar with them or not, they're a group of nurses who are registered nurses. They work at a level above sort of a staff nurse, usually at the same level as a sister or a charge nurse. They are specialists in an area, and I recruited 12 clinical nurse specialists in a variety. They worked in a variety of areas: diabetes, stroke, cancer, transplant, and asked them to consecutively record 2 interactions with patients. So I asked them to take a DVR, digital voice recorder, consent the patient, and record their interactions. And I asked them to make sure the interaction was going to be at least 20 minutes, and it could be, in some cases, it was in excess of an hour's interaction. And what I also did was I gave the clinical nurse specialist a small questionnaire beforehand asking about the context of the interaction, and then I gave her a sealed envelope so that once she'd done the interaction, she then looked at the sealed envelope, opened it up, and then answered the questions. So the clinical nurse specialists and the patients and the relatives that were involved in this as well were aware that the study was about communication, but they weren't aware it was specifically about humour. But when she opened up the sealed envelope after the first interaction, she was then made aware it was about humour, because I was asking questions at that point about, was there much smiling going on? What was your view about the degree of humour that was used? Was there any laughter, etc.? So at the point of after the first interaction, she might be aware that it was about humour, and then she would do the second interaction. So it was 12 clinical nurse specialists and 20 interactions in total. I also then did a number of bits of data collection looking at nurses and their peers. So that was informal settings, meetings and breaks, and that included field notes and audio recordings, and also did some work with data collection around patients and their peers, meaning that I was sitting around waiting rooms in various areas as well. And the data collected was taken over 18 months. So you had the baseline data corpus, which was this non-researcher provoked data, naturally occurring interactions, where I wasn't present. So that was the 20 audio tape CNS patient interactions. And then I also did 10.5 hours of field note observations with a clinical nurse specialist who was unable to consent her patients, and I'm going to tell you a wee bit more about that in a minute. And I did a field note observation of a focus group. And then I built upon that and then gathered more data that was researcher provoked. So I followed up some of the patients and the CNSs from the baseline data corpus, and then followed up other patients and other focus groups. Okay. So it was an attempt to try and study interactions and then try and find out each person's perception on it, and then try and do a focus group to follow up people's perceptions on whether humour had occurred or not. Because what I was quite clear about is I didn't want to speak to people about their experiences of humour, because they might not understand, you know, their humour preferences or whatever. It's much better to audio record it and try and get a sense of what's going on and then follow it up. And so that's what I did. So what I want to show you is the findings, and then I'll show you some excerpts and then contrast that. So what I found out was that the patients, in seeking to establish and maintain a meaningful and therapeutic interaction with clinical nurse specialists, they enact a good patient persona to varying degrees according to the context. Right? This good patient persona needs to be maintained, and it's reconciled with a use of potentially problematic and non-problematic humour. So the humour is therefore in those interactions used to deferentially package concerns, potentially problematic, or affiliate. So on one level it's a straightforward trying to build a rapport, so patients will use it to build a rapport, and then on the other hand they'll use it to package concerns in a non-threatening way to the clinical nurse specialist. So the middle range theory presented differentiates potentially problematic humour from non-problematic humour, and crucially suggests that how humour is identified is central to whether patients' concerns are addressed or not. Right? So if the clinical nurse specialists don't recognise when humour's happening, it's irrelevant what kind of humour's present, because they're then not going to make an attempt to unravel it. But if they could recognise the humour when it occurs, and then maybe recognise how the humour is presented, they could then be alerted to the fact that there might be something problematic about this interaction, and then attempt to address the problem. Okay? So two baseline, trying to affiliate and trying to deferentially package concerns. And just to kind of outline very briefly what I'm meaning about the good patient persona. So, this was a core category in the grounded theory. So it was suggesting that patients, there's a particular persona that they enact in those interactions that has particular dimensions to it. So they appear to be compliant, they are sycophantic, and when I say sycophantic, I mean they talk about things as being really great and fantastic. So their use of words is disproportionate to the help that they're being offered. So if you give them a tens machine, they might say that's super fantastic, marvellous, and it's as if you've given them £1 million, but it's a simple, straightforward intervention. So they're very sycophantic, use a lot of superlatives. They appear very positive and coping, and they quite often articulate that positivity. No, I'm being very positive, I'm positive thinking about this. They make sure that you're aware that they're independent, they're not depending upon you for anything. And they quite often express, particularly in the cancer field, something called displaced concern for others, not themselves. So they'll talk about being concerned about their family or their husband, but they'll never actually express concern for themselves. So this picture here is the good patient, and that particular persona is reconciled with potentially problematic humour if they're trying to deferentially package concerns, or potentially non-problematic humour, which is primarily affiliative. And what we could say is that this type, affiliative or non-problematic humour, is primarily incongruity. So these would be straightforward, incongruous utterances. So talking about their chemotherapy and referring it as semichem. My grandson says, have you been at that semichem again? Now, if that doesn't mean anything to you, it's a cheap shop that sells sort of boots-like stuff. So it's a play on words, you know, so it's quite incongruous. It's a playful way of looking at it. The potentially problematic humour that deferentially packaged concerns is primarily self-disparaging humour, so that's humour used against yourself, and gallows humour. Right? And you can actually see, even in short interactions, that if patients use self-disparaging humour to the exclusion of other types of humour, or with gallows humour only, I would strongly suggest there's a problem there that people then need to try and unravel. Right. What you want to see in a positive and you've got to remember that patients, you know, coming to clinical nurse specialists might have been diagnosed with cancer, they're worried, they're anxious, they're embarrassed, etc. Their actual sense of humour is going to be different from when they were well. So that's the first thing to remember. But equally, you would expect a relatively healthy display of humour, and everybody has their own humour preferences, would be a use of different types of humour. So somebody might use superiority humour, be sarcastic, they might have a wee bit of self-disparaging, a bit of release, and a bit of incongruity. Right. But if someone tends to have this more negative forms of humour repeatedly, then I suggest it's potentially problematic. So, to kind of summarise generally about humour and its use within the study, what was interesting was the asymmetry in the interactions. That the patients in that initial data corpus were twice as likely to initiate humour as the nurses and twice as likely to reciprocate it. What was also interesting was that CNSs rarely recognised when humour had actually taken place. Right? They tended to simply say it was nerves, or the person was just being really positive. Right? What was also really interesting was the different humour preferences. So for the clinical nurse specialists, they were more likely to express superiority humour, don't know why, incongruity, gallows, and latterly self-disparaging humour. However, on the other hand, the patients were much more likely to express self-disparaging humour, gallows release, incongruity, and superiority. So there are clear differences in the humour preferences of each group. And an important thing to say, potentially problematic humour, self-disparaging humour, it's not uncommon in interactions. This is a general research. It does tend to just occur once. Right? Although some people have self-disparaging humour as a sense of humour, and you do see self-disparaging humour in people who are depressed. You know, it's seen as a precursor to people that are depressed sometimes. But if it does just occur once in a normal interaction, the common responses would be contradiction, sympathy or compliment. So if I said, "Oh, I'm putting the weight on," "No, mate, you're fine, you're looking great," right? That would be how you would rebut it normally. However, we do know from other research that self-disparaging humour is problematic or unsatisfactory when it's the preserve of the patients and not the doctors. And there's been quite a bit of work done in this area that notes that when patients use self-disparaging humour, it's a problem. When doctors use self-disparaging humour, they're less likely to be sued. So there has been some work done in that area. However, in this study, what I'm particularly suggesting is that it's potentially problematic when self-disparaging humour occurs several times during a short time frame. Right? When you see it once, you see it then again, you see it again. So you just don't see it the once only, as suggested by previous research. It tends to be patient-initiated, which we know has been agreed by previous research. It tends to exist in isolation, so you only see self-disparaging humour, or you see self-disparaging humour, but you might also see gallows humour. Right? So in those circumstances, you know, I would suggest there is a problem. And the woman who actually presented the core category of a good patient. I saw her, listened to her tape when she'd been in for a radiotherapy review. And this was an interesting person because the woman was known to have really good social networks. She was known as being really positive and cheery and coping, but she always arrived at the clinic on her own, despite the fact she had her husband and a really good family and social support. She went to the clinic alone, which was kind of incongruous. And when the audio recorded interaction, or rather the CNS did, I remember listening to the tape thinking, this woman wants to ask something, this woman's got a problem. Didn't know why I was thinking that, you know. And then eventually, before she went out the door, she blurted out what it was she wanted to ask. But through that short radiotherapy review, she repeatedly expressed self-disparaging humour. Right. I then followed the woman up. She went for surgery, and I waited, then was back in touch with her and followed her up and did another follow-up. I did a follow-up interview with her face to face, and what was fascinating actually discussing it with her then, because she at that point exhibited different types of humour. So she was using superiority humour, she was using incongruity, release, and so on. Very, very different from that point in time. This was a woman with a normally well-developed sense of humour and a good social network. But at that point in time, it was very, very different. So what I want to show you is a kind of example, not from the particular core category, but from a patient who, there was an audio recording of an interaction between her and a clinical nurse specialist in pain management. So this lady has phoned up, got a late appointment, she has chronic back problems, and she's going to the pain management clinical nurse specialist to be shown the use of a TENS machine, which is a trans-electrical nerve stimulation. It's something that disrupts the endogenous pathway, the normal endogenous pathway of pain, disrupts it, and it therefore gives a bit of pain relief at that point. So it's a kind of electrical nerve stimulation analgesia. So she's going to be shown how to use this. So the CNS has never met the woman before, and this is the first time that the woman has appeared. And this is just a short verbatim account of this part of the interaction. So this is Carol, this is a patient. Well, I've been to a chiropractor, so I know a lot about it. CNS, excellent. Carol, the different things, but that didn't help me either. And she laughs at the end, so there's post-construction stance laughter. The sort of CNS goes to laugh and then goes to talk, and then Carol continues unabated. £2,000 I spent in chiropractic treatment, and then she does another out breath. And then quietly the CNS is trying to interject and says, I think, but sometimes you've just got to try, and this last part is important. Oh, I'd try anything to get rid of this pain, because now it's actually keeping me awake at night again, and this part is spoken really, so this denotes that this part is spoken really quickly. Right. So apologies for the colloquial part of that if you didn't catch it. But perhaps a couple of things to point out from that are that, you know, she's saying she's been to a chiropractor, she spent £2,000 in a chiropractor, and then further on in the interaction she's talking about how she's, you know, she uses self-disparagement to talk about how she's tried to use exercise to combat her pain. She also lets it be known that she's lost her job as a cleaner because of her back pain, right? And basically she's saying here, I'd try anything, I'd be really compliant, I'd do anything, and I'd do anything to help myself because I'm really independent, I'm a really good patient. So this is really locked into the whole good patient persona here, because now, and she's making another complaint here, actually it's keeping me awake at night again. So she's escalating the pain. So she's basically saying, this pain's a massive problem, it's getting worse, I'm doing everything I can to deal with it. You know, I'm going to a chiropractor, I paid out that money, I've been going to exercises, you know, I've lost my job. And every time she says it, she kind of laughs at herself in that sort of self-disparaging way. So what's interesting about it is, what she's saying is actually really negative, but how she's saying it is really positive and cheery and using humour, albeit self-disparaging humour. So it's quite incongruous. So you would think in that situation, well, how would the CNS respond to that? Because if you look at the other work and it talks about, well, if you have one instance of self-disparaging humour, you either prefer a compliment or you negate it. But in this bit, the CNS has actually been trying to be very positive, so she's not trying to negate it or put her down. She's actually still trying to be very positive. So what's interesting is, what was the CNS's perspective? So there you go. The CNS thought everything was hunky-dory, right? CNS thought everything was positive, the woman was smiley. This whole use of humour wasn't that she was trying to deferentially package concerns that she had. This use of humour was because the woman was being positive, right? Now, it's difficult to say what the motivation is, right? But if you always assume that the use of humour is positive, or it's about anxiety nerves, which was another interpretation of it, then you never then actually then begin to ask the person, how they're feeling about it, how they're trying to cope, and then try to open up that conversation, because this woman's clearly having major problems. So if you were to take that baseline data corpus and you talk about good patience in humour, it's quite clear to a certain extent that patients want nurses to use humour, and I haven't shown you but this was collated through the focus group. Patients are much more likely to initiate humour and reciprocate than nurses. Patients use humour to affiliate with nurses and encode concerns. Unfortunately, nurses in that data corpus appear to fail in the main to recognise humour and therefore address the concern. And nurses and patients have different humour preferences. And that's the good patients. However, you can see there that baseline data corpus came from this stuff up here, and then there was some follow-up. But there was also this negative case that appeared. There was 2 clinical nurse specialists from the initial baseline data corpus who were unable to consent patients. One was a palliative care nurse who worked in an acute care setting, and you can maybe understand why that might have been difficult. And the other was a girl who worked she was a gynecology nurse specialist who worked with female drug users. And she worked in a sort of peripatetic setting in various clinics, outreach clinics, methadone clinics, etc. So I interviewed both of the people who couldn't consent for the purposes of rigour, etc. So I had an interview, and I interviewed in particular Heather, who was the girl who was a gynecology nurse specialist. And when I interviewed Heather, I never told her, she still didn't know what the focus of the study was at this point. She'd been unable to consent her patients because they were never in long enough. They were too busy going to see a man about a horse, right? Or they were in a hurry, right? Or occasionally they would say they would be worried about getting audio recorded because it reminded them of the interrogation room in a police station somewhere in Glasgow. So she found it quite difficult to get them to agree to audio recording. But it became quite apparent talking to Heather that she was really well informed about humour, and she talked about using humour and the importance of getting people engaged in their consultation. And she also talked about exclusion zones, right? So she talked about how to initiate it, but she also was aware that there are certain areas that you don't go. So on that basis, I thought, it's interesting because you clearly use it as an initiation strategy, whereas the nurses in that other data corpus didn't, in the main. There was 1 or 2 who did, but in the main they didn't, but you clearly do. So that made me think this is different, and could this be a negative case, right? And I'm thinking, well, you've got these good patients, so what about these bad patients, allegedly? Bad patients, Felicity Stockwell did a seminal text way back in the 70s talking about the unpopular patient, tried to create a typography of someone who was unpopular, who was demanding, the opposite of the good patient, someone who's demanding and non-compliant, etc. There's been stuff written about bad patients, principally around drug users. We also know there's an awful lot of prognostic pessimism when nurses working with drug users. We know that group certainly are difficult to engage in health services. We know for a fact they're non-compliant, they're non-attenders, tend to be negative, and they maybe just don't have displaced concern. To kind of put it into a very simple way of looking at it, if you were working in a surgical ward and you had a drug user in and they were discharged, they wouldn't leave you a box of roses. That's basically where it comes down to, right? So, Heather, the negative case, a case that contradicts emerging findings. From that initial interview and the discussion, she was clearly aware of humour use without prompting. She reported initiating humour as a necessary engagement strategy. She noted some humour exclusion zones, but she also noted that patients actually rarely used humour. And that was interesting because that was the opposite from the original group, where patients were constantly trying to use humour to engage with the nurse. So the data collected with Heather was 10.5 hours of field note observations, the 90-minute follow-up interview that I did as part of trying to find out about her non-consent. And the participants were Heather herself, who's the CNS, a midwife, a specialist midwife who worked with the drug users, and various others who were at the various areas that Heather actually worked at. And this was all done through observation and field notes. There was no audio recording except for the interview, which was audio recorded. And what emerged in this setting was a particular type of humour use, something called harsh humour, a coarse and candid discourse. It was a kind of superiority humour, sarcasm. It always had a particular topic, like a particular target of abuse common to the participants. So that would be drug use, sex and men. That was the commonality they had. How humour was posited was very upfront and frank. There was no subtle encoding, nothing was deferentially packaged whatsoever. It was in your face. You knew exactly what the intent was. And quite often it was used, it used profane or even violent terms. So it was very different from the sort of more attempt to deferentially package and be more nuanced in the baseline data corpus. This was very much upfront. And it was harsh humour in the sense that it was humour that's unpleasant and exacting to the point of being cruel in action, but not necessarily in effect. Right? So it was a means of expression, not necessarily an outcome. So Heather, she was, very briefly, sex and reproductive health care for female injecting drug users. She worked in a variety of clinic and outreach settings. She door-stopped people, so she'd hang about, you know, and if she saw somebody coming in that she thought might need a smear and an implant, you know, a contraceptive or whatever, she would try and chat to them and try and show them into a room. So it was a very opportunistic way of working with a client group. And because they're a difficult to engage group, you've got to develop different ways of working. So it was a very peripatetic mode of service delivery. She worked in a multidisciplinary team, so she might be based at an addiction service, or she might be in a methadone clinic. Some areas were structured, some were ad hoc. The pregnant drug users were seen by Heather with a specialist midwife, and Heather was a very experienced nurse, only over 20 years experience with a specialist qualification in gynaecology. So, what I want to show you is a couple of field notes that are very different from the other one. This is a field note of Jean, who's a patient who's 37 years old. She's an ex-injecting drug user. She was on her 8th pregnancy. Right. She has a history of violence in the terms that she's been beaten up, and she's been sexually assaulted, and she's been subject to child sexual abuse in the past. And what I'm going to show you is I've actually managed to write most of the stuff down verbatim. So try to capture it as best we can. So this is in the clinic with Kay, who's the midwife, and Heather, who's the CNS. And I'll just give you a minute to read it. What do you think is particularly interesting, or what things do you note from it? There's lots of humour use, isn't there? There's lots of laughter, there's lots of smiling. There's quite a bit of sarcasm. And even if you go from the start, now you remember that Kay is the specialist midwife, she's never met this Jean before in her life, right? So she's sitting on the phone, Jean comes in the room, right, I'll let you go, Jean's finally turned up, right? Now that's quite sarcastic. So that's quite a risky strategy for a start, isn't it? You don't know her. Right? But no, Jean laughs, and she comes in with her daughter, who's about 18, 19, and the daughter laughs as well. And then Heather appears, and the interesting thing about the two of them is they seem to work as a comedy double act. So she would come out with a big bulky case notes and put them on the desk. And then she's sarcastic about the case note. Look at them, they're like War and Peace. Now they would be if she's had 7 pregnancies at this point, right? They'd be pretty big case notes. And then Kay points at the case notes. Whose writing's that? That's the biggest writing ever. More sarcasm for her. Now she doesn't say, fuck's sake, she mouths it, right? She looks at Jean, who laughs. And then, you're in baby 8, is that right? Her eyes widen. And then Jean laughs, aye. And then Heather, who's out of sight in the cupboard at this point, you can hear her saying, well, we'll need to find out what it's caught, isn't it? Right? Which again is quite nonsensical. She comes out, raises eyebrows and looks directly at me and Jean's daughter, who laughs, and Jean smiles. So the humour starts the minute Jean walks in the door, and it continues, right? And they're both working very hard to get Jean in and make her feel quite relaxed and engaged. Yeah, there's quite a bit of sarcasm, but it seems to be working because it's been reciprocated by laughter and humour support through smiles as well. Yeah.
I was going to say on line 8, where Kay says you're on baby 8, is that right? That's really uncommon, as far as I know, in terms of, it's almost, I don't know kind of the word, it's very informal, it's kind of the kind of thing that you'd expect to hear between friends. Oh, you're on baby 8, rather than, oh, I understand you've had 7 pregnancies and did you have any complications, kind of going down the formal route. And I think that's very effective. It would be effective at putting her at ease. It's almost like an informal, friendly setting. I think that's quite effective.
Yeah, I mean, everything about this is every line, every bit of that interaction, they're working to involve Jean in it. And you've got to remember, this is someone who doesn't engage with health services, right? Doesn't have anything to do with them, probably has been to hospitals, probably been treated quite badly. She's probably quite disenfranchised. Probably doesn't really rate healthcare workers very much. So you've got to work extra hard to get that person in, right? Interestingly, it doesn't just stop there. I'll show you next brief excerpts. So Kay says, this isn't a new thing that you don't keep antenatal appointments. And then Jean goes, no, and laughs. Good, I'm not offended then, right? So then she's working very hard at being non-judgmental. Okay, so you don't just no turn up for me, right? That's fine. So then she tries to subtly try and get her mobile number off her. So she asks her if she's got a mobile number so she can contact her. Jean indicates she can't remember her number. And then Kay says, I'm just trying to track you down. And what about the health visitor? Does she shout at you? Never seen her. Ha! Right? So it's almost quite complicit. Right? And you think, is that quite collusional? I'll show you one more before I kind of summarise. Heather asks Jean if she takes any drugs, and Jean replies, speed. Heather, I'm no surprised I'd be on speed with 7 kids. Right? And then Kay, what about your partner? She hesitates and then says, dope. Aye, him and the rest of Scotland. Right? So you look at that, you know, and you think, well, I don't know, is that quite complicit? You know, are you actually condoning this whole? And you've got to remember, this group does live at the margins of criminality in terms of drug use. So they're used to being told off for what they're doing. Whereas actually it appears here that Kay's saying, well, I know, but what's happening here is interesting, different levels. I know about drugs. Kay and Heather saying, I know about drugs, I've got the knowledge about drugs. I'm not judging you, right? But we can use your drug use because that's a commonality between us. and I'm going to use that to try and engage with you in that consultation. You might think that's quite superficial. They're just having a general chat and it's quite friendly. But actually, during the course of this interaction, it is kind of therapeutic because she's trying to get her mobile number off her, right? She's tried to, ask her more questions about impending pregnancy. Actually, during the course of the interaction, she does an ultrasound scan. She gets a scan off her. That's Kay, the specialist midwife, and Heather does a smear. Right? Now, you might think, what's so triumphant about that? I don't think there's anybody, well, females in the room, who ever enjoy having a smear, right? Drug users aren't any different, and actually trying to get a smear off a drug user is incredibly challenging. The fact that, Kay and Heather, during the course of this consultation, get loads of information off her, get a smear and get a scan is, I think, justification for how they're going about it. If they hadn't worked really hard at the comedy double act and getting her in and getting her relaxed and shown that they're not being judgmental, would they have got the smear? Would they have got the scan? Would they have got anywhere with her? I don't think they would have. Right? So I suggest that it's therapeutic. Right. And then Heather illuminating some information as part of the original interview. You'll get the ones, in front of the main patients. I need to see you because I've got a discharge that could kill a horse. Right? And the laughter tape's primarily mine, just having had a fit. Right? And then Heather says, okay, we'll discuss that later, maybe, but maybe no over the macaroni cheese. Right? And then, of course, I then fall down, collapsed at this point. The interesting thing about that was the initial interview with Heather, when I then decided this is something different I need to look at. So she tells you this story, it's a true story. She walks into a room and it's a mixed sex group, men and women, and this girl comes out with us. Now the girl, quite often you get conversations like that, it's partly maybe just about them not having the social parameters that maybe everybody else does. It might also be an attempt to shock you, to see if you're actually worthy of their attention. But either way, okay, we'll discuss that later. Maybe this second part, but not over the macaroni cheese, wasn't said to the patient. It was for my benefit as a fellow nurse, because she knew that I would buy into that whole, and there's a whole separate paper on the nurse-peer interactions. So to kind of move towards the end and kind of summarise, bad patients different from the good patients. There's a definite awareness and recognition of humour by the nurse and by the midwife. There seems to be a deliberate engagement strategy, repeated initiation of humour by the nurse. There's specific humour types, very specific humour types, drug use, sex, men, that was risque and risky. And the humour was very particular, it was harsh, it was profane, it was upfront, it wasn't coded, it wasn't subtle, and it wasn't packaged. So, to kind of summarise the point I'm trying to hopefully making is, I think it's something to do with how nurses perceive risks, or part of it might be about that. Why do some nurses, that's badly worded, sorry, I've never checked it, why are some nurses less likely to initiate humour and or lack humour awareness? Is it because they're too busy, they're too task focused? Is it because of this ingrained notion that humour is using humour as unprofessional, so that humour and professionalism are mutually exclusive terms? Is it because you have to actually establish your competency prior to humour use? Right? And nurses are very professional individuals, and we need to be seen as professional. And once you realise that, we might engage with you. Or is it just that nurses don't have a sense of humour, or a very limited sense of humour? Well, it could be any or all of these things. Right? However, I think there's another thing to throw into the discussion. Is it about how nurses perceive and manage risk? Is that what's relevant here? Nursing's a risk-averse profession. The maxim by Florence Nightingale, to do the sick no harm. Right? So we know these days in nursing that there's loads of algorithms, loads of checkboxes, everything's controlled by paper, whereas in the olden days, I count myself in this, back in the 80s when you worked and staffed in the wards, everything was in here. You looked at a patient, you knew what needed to be done, you didn't need to tick boxes and write stuff down at the end of the bed. That's a personal view. Is it because there's low self-esteem in nurses? Right. And that partly compounds the whole routine and checklists. You know, it used to be that if you read the work by Isabel Menzies on anxiety as a defence, that's an interesting treatise on that whole aspect. The interesting thing about nurses have one thing in common in particular with drug users, and that is low self-esteem, right? But also at the same time, there's a link between hedonism, risk, and increased sense of humour, right? And there's also a link between improved psychological well-being, social support, and good sense of humour. So why is that relevant? Well, professionally, nurses aren't risk takers. Personally, they might be. But Heather and Kay, who work in a particular, what we would term a non-accomplishment setting, right? It's where you work with uncomfortable ambiguities on a regular daily basis, where you maybe don't achieve as much as you might do in other settings. It's quite a challenging thing to deal with that on a daily basis. So a different type of person needed to do that, who has a different perception of themselves, a different type of competence, who is prepared to take a risk, and who might even have taken a risk in their personal lives as well. And that's why they've got more of a commonality with the people they're actually working with. So, to summarise and finish, humour can be used effectively, I think, to engage with all patients, but specifically difficult to reach groups. Does non-accomplishment work attract a specific type of health worker with particular humour, for example, hedonists? There's a certain irony in a way, isn't there, that bad patients get engagement while good patients are left wanting, right? But there is a caution about advocating similar uses of harsh humour in different settings. It is a particular context that you could use that in. And if we were thinking about applications, I do think healthcare professionals should take humour seriously. I think you definitely need an awareness of spontaneous humour in healthcare interactions, where we should be teaching it via communication inputs. We need an understanding of humour use, particularly potentially problematic humour use. We need to consider what would be the appropriate initiation and reciprocation of humour. We need to look out for that good patient persona and make a more proactive attempt to engage with people. I think at the moment we too task focus on checklists rather than looking at the person in front of us and actually dealing with them rather than ticking boxes. And I do think there's the need to carry out further research longitudinal, and I think one area that is really worthwhile looking at is to look at humour use and resilience building in nurses. Because when you look at the girls that worked in the non-accomplishment setting, they're working there for years. They're working in a really difficult area for years, and they don't have a bad humour use, but they clearly are able to cope with it on a daily basis, and there's maybe a lot that could be learned from that could be transferred to the other areas where the nurses are working with good patients. Thanks very much for your time.
Well, thank you, May.
I've got some.
We just have a bit of time for a few questions. Does anybody have any questions?
Hello.
So,
It's fairly obvious, I think, that everyone you involved in the study was female.
no, not everybody involved in the study.
Male nurses?
Yeah, there was male nurses involved, yeah.
Okay.
Mm-hmm.
And was there any difference in behaviour between the way the male nurses dealt with patients and women?
No, I wouldn't say there was particularly any difference. In both groups, interestingly enough, there was male nurses in the harsh humour setting as well as in the other setting.
Yeah.
There was no differences.
Okay.
From what I observed, that's not to say there might not be if you did.
No, I
yeah.
just assume that when you think nurses, most people think female,
Yeah.
and you didn't allude to that anywhere in your presentation.
Uh-huh.
So I just assumed.
I've just taken it for granted that nurses are female, but no.
Well, I think
Yeah, most people do, yeah.
Because I run an organisation called Funny Women, so I'm dealing with women's humour all the time.
Uh-huh.
And my theory is that we do deal with humour differently,
Uh-huh.
and therefore there may be some background to that, where we're less comfortable around.
Oh,
humour
there absolutely is. I mean, there's a whole range of research around about gender differences. Women are much more likely to show humour support than men,
Yeah.
things like that. I mean, there's lots of gender differences that have been noted, but I didn't see any differences, but there was only maybe 2 or 3 males across both sectors. So that.
Thank you.
Aye.
I'm an ex-nurse and now I'm a professor of sociology, so I was interested in what you have to say from a lot of different points of view. But one thing that really struck me, which I guess again is quite obvious, but the two who were working, so Heather and Kay, those two, obviously they'd worked together for a long time. They were like a double act.
Yeah.
You're single, you're clinical nurse specialist, they were working on their own. So in a way it's a bit like a rehearsed routine almost for the two working in that particular area. I wondered, you probably wouldn't expect to find that just
Well, no, but even, I mean, the excerpts I showed you there where Heather, it so happened it was Heather and Kay, but there was other excerpts when Heather was on her own and she still had the same, but she just didn't have Kay to bounce off. It was just more overtly like a comedy routine double act. I mean, there was even one point when Heather tripped over scales and it made a big sort of dramatic fall. But she certainly used, she didn't hold back when Kay wasn't there. She was very much the same person.
Yeah, no, thanks for that. It's very interesting. One of your conclusions, obviously, that nurses should take humour more seriously. But
Yeah.
Humour can be a very intangible thing. Some people,
Get.
crack more jokes at work than others, etc. So are you sort of saying it should become more formalised, that almost nurses should learn how to use humour in their workplace in the same way that one might learn to be a stand-up comic or something?
No, I think it would be that. I do think nurses need to be made more aware of humour, and I do think they need to understand the different types and consider different presentations of it. So I think we need to raise awareness. But I think what I would say, I don't think I would want to teach people how to be funny in that interaction, but I would want to make them more relaxed with themselves so that they could feel they were more relaxed and less uptight as a professional, that they could then begin to engage. I think we still have a problem that nurses don't, there's still that power imbalance, and I think the better nurses, the way you get more engagement like Heather and Kay, is where they're much more relaxed with themselves. And there's a greater honesty about the interaction. So I would want to work with people, and that's where the resilience building would come in. You could get people to feel better about themselves and more relaxed, and then you would get a better interaction, and that would involve humour. It would be a natural progression, I think.
Do you perceive that if there was more kind of humour in nurse and patient interactions, do you perceive that there'd be any problems, such as patients seeing nurses as unprofessional or almost mocking their situation? Do you think it could go more the other way?
I don't think. I mean, when you look at what patients are, certainly in the focus groups, and again the focus groups were done that we discussed communication generally, and then went on to humour. It's quite clear that they saw humour as a recognition of a connection between the two. And when you think of nurses working where patients are terminal, been diagnosed, and it's really difficult, you need that connection to make that connection with people. I mean, there was one example, and I think it's a good thing because your point's valid. Patty Wooten, who's a nurse humourist in the States and has done some work, her view is that you need to establish competency before you use humour. I don't agree with that. I think you can establish the two concurrently. And one example from the study was there was a quotation we did. There was a focus group of prostate cancer patients, and one of the guys gave an example of when he'd been in to get his an operation, and there was 8 of them, and he was number 8. And he says, it's quite tense, and you're waiting there to go in, and they were one wheeled in after the other, and the nurses were nice and cheery, and they were bright, and they were keeping you going and egging you on. And he says, and then I was number 8, and number 7 came out. And number 7 had a reaction, and they were all running about trying to get various drips up and stuff like that. And it was all very anxious, but the nurses were still very humorous, very bright. No, you're fine, we'll get you in next, no worries now. And look at you, you're looking good, give us your teeth. And, and been very sort of moving them along. And he says he thought it was right, because if they'd have been actually worried and quite tense, it would have escalated. their anxiety. So I do think there are aspects where, you know, I know for a fact in a lot of said nursing situations that I've dealt with in emergencies, you know, and some of them can be bizarre. But, you know, it's sometimes good. It's an indication to the patients and even other staff members that I'm in control, I know what I'm doing, because I'm confident enough to be able to express my humour at the same time. And so I do think you can do it concurrently. I don't think you need to establish yourself first and then use humour.
Can I just ask, you were talking about the difference in how the CSNs would use humour. The bad patients, they used humour, they initiated humour more than the CSNs. Do you not think that's down to kind of the psychological level of how we receive and reciprocate humour? In the, you know, we all compartmentalise our humour to social situations, social groups. I mean, what's acceptable to 3 blokes down the pub is not acceptable to 3 blokes. One bloke, his aunt and his granny. He wouldn't use the same humour. And we all do that. Do you think it's because the people with cancer, they're looking to you for answers?
Mm-hmm.
So you tend not to use that, whereas the people who are at the drugs clinics and the bad patients are coming into you for a quick fix. And do you think that's just where the level is in different compartments? Yeah.
No, I think that'd be far too simplistic to go along that curb. You know, I don't think it's as simplistic as that. I think there was one in one of the focus groups I did with breast cancer patients, and she talked about getting into the clinic, and there was a big discussion, and that was held in one group. There was a lung cancer group, there was, you know, men discussing the same thing as well, and it was about how they perceived the humour. And at this point, they didn't know the study was about humour. It was emerging that this is what they were talking about. And he interestingly said, you know, you get into that clinic that's really, really busy, and you're really anxious because you're waiting on this result, and so on and so forth. And so she felt she got a better interaction with the nurses, right, when she talked about something other than her cancer.
Yeah.
Right, so she talked about her hair getting done, or, you know, something that was on the television last night, or the men would talk about the football, or, you know, so she deliberately chose a non-cancer discussion, because she thought you have to engage with the nurses on a personal level. If you engage with them on a personal level, you might get better treatment for them, and they'll care for you more if you do that. So, and I think it is the whole thing about one of the problems in teaching nurses is that I always say to them, you work with patients that you don't necessarily like or get on with, and it's the whole thing. Some patients you think, oh, you're the same age as me, you're married, you've got 2 kids, you live in that area, and there's a whole load of commonalities, and it's easy to engage. But in other people, there's not the same commonalities, like drug users. So you then need to work with what works with them. So I think it's about adapting, and I don't think you can just say, well, it's normal to have that conversation here. It's not.
I'm not putting it forward very well, but what I'm saying is that we deal with because psychologically we all deal with humour in a different way, and we compartmentalise that to environment and social group in our heads, you know. So what I would say amongst you guys is not what I would say to the guys in the office. It would probably be a harsher humour. Guys I'm working with in the office. And I just wondered if that plays on the nurses when they're in those environments. Just, you know, that's why they didn't spot the humour, is because they're not thinking on an emotional level. They're on their emotional level and their environmental level about humour when they're dealing with cancer patients.
Yeah, I think what they're.
Whereas the people dealing with drug dealers and that see a kind of non-accomplishment as a kind of futility in what they're doing. So they see humour in that.
Again, I don't.
That's why they use it that way.
No, I mean, I think there's a lot more I could get into with particularly the harsh humour stuff, particularly when you looked at the type of humour that was used amongst the peers, and it went up a notch slightly in terms of how it was used. But I still think part of the problem with nurses not using it and not recognising it is because they're not actually engaging with the person. you know, and I do think, and some of that's about, there's been some work looking at older nurses are more likely to use humour, you know, and there's been discussion around about, is it older nurses more likely to use humour because they're more confident and assured about their own competency, so they underestimate the risk involved. And I do think you do see that with a lot of nurses, that they're just, the patient's in front of them and they're not actually engaging with that person in front of them, they're engaging with the condition and it's once removed. And you need to kind of relax a wee bit and align yourself, and then you'll get a better interaction. But I would say that not just as a nurse, I would do it as a teacher and dealing with students as well, but not everybody would do that or be comfortable doing that. But I would argue as a nurse, you should be. Don't know if that's... Yeah.
Yeah, thank you very much. I wanted to ask in how far the type of humour you presented here, you would say, is specific for healthcare settings, or one could think of comparison to other situations where there's a client-professional relation, and if you have any ideas of how this kind of humour used in these situations and taking part is specific to this field or to a specific situation that.
I think, I mean, there's been work done in different other settings, and some of it which drew upon is there's been some work done among social workers, and particularly in the non-accomplishment settings, and also forensic psychiatry, again a kind of non-accomplishment setting. There was work done in the late 50s, early 60s, famous work by Roselaw Kosa, looking at forensic settings. There's also been stuff done in other institutional settings, for example, body handlers, policemen who acted as body handlers during the Piper Alpha disaster. There's also been some work looking at sex workers and how they use humour as a currency amongst themselves and to build solidarity. I do think there's a lot from here, particularly around the identifying potentially problematic humour that you could translate to other settings. Particularly when you're working with good patients. So I do think maybe social workers and others, there are things there that they could be cued into thinking, well, wait a minute, there's maybe something else I need to address in this. So I do think it could be transferable to other areas.
Right, so I think if there are any lingering questions, perhaps we can take that into the drinks reception. So I'd just like to thank May again for a really excellent paper, very interesting and very enjoyable. So thank you very much.
Okay, thanks very much.